Hello, you ready for me to play devil's advocate? I'd like to thank Sky for the opportunity to debate this today. And it's the con. There's a lot of words here. There's all, there's should, and there's primary PCI. So the con is that all patients in Bangladesh
You are
can't
not
really
audible
undergo
clearly.
primary PCI. Sorry? Oh,
You should
can we
move
share the
forward.
slides, please? Yeah, all right. So we know that in STEMI, timing is everything. We know it from this seminal slide from the 1970s that at 40 minutes, only 55% of myocardium is salvageable. At 3 hours, only 33% is, and at 6 hours, only 16% is. And this works for both primary PCI as well as fibrinolysis. We know that time is myocardium. And you look at all the guidelines and they'll tell you that primary PCI is the gold standard for STEMI. There's no debate about that. It's whether all patients in Bangladesh should be undergoing it. But it comes with a caveat that it has to be done within 120 minutes of the patient presenting to first medical contact. And the event you cannot, then you should be going for a fibrinolytic strategy and then transferring the patient to a PCI center for either rescue PCI in case of failed fibrinolysis or a routine strategy between 2 to 24 hours for revascularization. So we have a lot of important time targets. It's not just two procedures, it's also maintaining to time in order to optimize those procedures. And therefore, we have what is called the reperfusion paradox, where even in the United States, where there are far many more cath labs than in Bangladesh, many STEMI cases don't present to PCI-capable hospitals. And among those transferred, only about a fifth actually achieve the recommended transfer of dose to balloon time of less than 90 minutes. So a lot of patients are actually denied the benefit of pharmacological therapy. And pharmacological therapy is not just fibrinolytics alone, as will come down later. So hence the pharmaco-invasive strategy, where you first fibrinolyze the patient, and as I mentioned before, take them to the cath lab to see how it's done. But why is primary PCI not the best option for all STEMI patients? Let me walk you through what happens in this country. A patient develops chest pain. He thinks about it. Should I go to the hospital? Should I not? Should I go? Should I not? There's this indecision, and then there's this time bomb kicking. When he decides to go to the hospital, you can't really get an ambulance. We all know the state of ambulances in this country. He gets his private car, he gets his CNG, maybe a rickshaw, and when he gets to the road, this is what you get. You get a traffic jam where there's additional delays into going into revascularization. Once he arrives at the emergency, comes with a STEMI, and even there, you have the options of primary PCI and fibrinolysis, and then you have even more time wasted because he thinks, should we undergo primary PCI? Do I believe this doctor that he wants to take me to a procedure immediately after coming to primary PCI? So there's a lot of lack of awareness and a lot of less science communication in this country that needs to be worked on before we can use this as a strategy. And even within the hospital, if the patient presents to, Dr. Mahbub Rahman showed us, there are only 65 cath labs in the entire country. If a patient presents to a hospital that has no cath labs, or if there is no round-the-clock PCI, there'll be delays, further delays, precluding the whole objective of the advantage of primary PCI, and then on delays in transfer. So can evidence generated elsewhere in other countries with better facilities be actually extrapolated to our context? And this is a study done by our group at our center, where we found that over almost 50% of ACS patients presented more than 12 hours after the symptom onset. So there are lots of late presenters. And the real-world data of over 1,900 patients from our large ACS registry found that the primary PCI rates in actuality are only 6.2%. We just can't do it. And we've already seen that there are only 65 cath labs in the country, largely Dhaka-centric. So the feasible and logical solution is a fibrinolysis or a pharmacoinvasive strategy. I'm giving you two options as opposed to just one. And the primary mechanism is that it prevents the reocclusion that can happen in about 10% of patients that have undergone fibrinolysis 24 hours later. So we know what it is. It has a time limit of 24 hours. We know that there are both fibrin-specific and non-fibrin-specific lytics. We used to use a lot of streptokinase. I believe it's still done so outside of Dhaka. We now have the option of tenecteplase, and the guideline recommends a fibrin-specific agent. So we have tenecteplase. We should be using it. And if you look at it, the patency rates are also far superior. It's 85%, I suppose, not as high as primary PCI, but we are not asking you to stop at a lytic. We are asking you to go to a pharmacoinvasive strategy at a cath lab. Or I'm sure you can transport any patient within the country of Bangladesh over the 2 to 24-hour period to reach a cath lab if he can afford it. But as I said before, pharmacoinvasive is not just the lytic. You also have to make sure that the patients presenting to the primary care physician loads them well with the dual antiplatelet therapies appropriately and makes sure that they get low molecular weight heparin as well. So let's look at some of the data. There's plenty of data to support this strategy, as well as a pharmacoinvasive strategy. We have data from the STREAM trial where pre-hospital fibrinolysis with timely coronary angiography resulted in effective reperfusion in patients with early STEMI who could not undergo primary PCI within the 1 hour. They, of course, reduced it to 1 hour. However, it was associated with a slightly increased risk of bleeding. The transfer AMI was a strategy to transfer the patient for within 6 hours after fibrinolysis, was associated with significantly fewer ischemic complications than the standard treatment and similar rates of bleeding. In Northeast STEMI, where there were rural patients, immediate transfer, although it didn't improve the primary outcome, it reduced the rates of death, reinfarction, and stroke at 12 months, which is the objective of what we want to achieve. The early Mayo trial was a non-inferiority randomized control trial where patients presenting within less than 6 hours after symptom onset with a pharmacoinvasive strategy of half-dose alteplase versus timely PCI, there was a greater benefit and complete revascularization, complete myocardial reperfusion when compared with primary PCI. Real-world data from the Mexico City registry, which also has a lot of traffic and not enough cath labs, not as similar to Dhaka, but quite as similar, found that MACE and bleeding were not really different among patients who underwent pharmacoinvasive versus a primary PCI, and this was data published in 2021. Also from Canada, registry data found that a pharmacoinvasive strategy was associated with improved ST segment resolution and enhanced outcomes within 1 year compared to primary PCI. So the myth that it's not better is incorrect. It can be better. And if we can't optimize giving PCI to all patients, India has developed a very interesting hub and spoke model of STEMI care where they fibrinolyze patients and transfer them to the cath labs that have primary PCI facilities. So pharmacoinvasive strategy works. This is a case from just a couple of weeks back. A patient had presented with STEMI, was thrombolyzed luckily at an outside center outside of Dhaka, came to us, we did the angiogram, we can see that TIMI3 flow is established. So that is the objective of treating primary PCI as quickly as possible, the establishment of TIMI3 flow, which allows time then for a pharmacoinvasive strategy and stenting thereafter. So the primary PCI can be the gold standard, but can we actually achieve it realistically in our setting? This whole pre-PCI for all STEMI paradigm can sometimes even be counterproductive. There can be unintended negative consequences. We might be denying patients optimal care and timely care. There may be delays in accessing timely PCI in those presenting to the non-PCI hospitals. There might be a decline in the ability to provide state-of-the-art fibrinolytic therapy. In fact, there's data to show that as well, that you go on saying primary PCI and patients are not even given fibrinolytic therapy on time and they get nothing. Then there are also the proliferation of lots of low-volume standalone primary PCI centers. And more importantly, the fact of the matter is that there is recent data, not old data from 2003 in Garcia 1 or 2006, stating that pharmacoinvasive strategy as an alternative to primary PCI actually works. So the focus should instead be on an integrated therapeutic strategy. And I humbly offer that there should be policies and interventions to reduce pre-hospital delay, because that is the real problem. There should be better science communication and patient education so that they don't ignore symptoms and they don't question the doctor's decision in this country. There should be improved door-to-balloon time. We should be reporting it as a cath lab quality metric to the BSCI. We shouldn't be making traffic a problem. Decentralize cath labs. Don't have so many in Dhaka. Do a hub and spoke model. Make fibrin-specific lytics available nationwide so that patients don't have to have streptokinase. They can have a bolus of tenecteplase. Increase emphasis of overcoming undertreatment. Timely fibrinolysis. Ensure loading and transfer them as soon as possible. And importantly, we have to generate local data to inform local policy, because everything is anecdotal and hearsay, and that just doesn't fly in this world. And we have to leverage digital health interventions, like maybe ECG interpretations via apps to quickly diagnose patients. Because the ultimate objective, ladies and gentlemen, is that this country has 169 million people, and we want equitable STEMI care that serves all population demographics. Thank you.
Thank you.